Hi, everybody. My name is Rawan Saab. I am a doctor who takes care of diabetes. So they call us either diabetologists or endocrinologists. And I will be talking a little bit about what is diabetes, what are the numbers that you should be looking for, and what should be done in case like you're diagnosed and you want to get treated. Rebecca?
So hi everyone. For those of you who don't know me, I'm a licensed clinical dietitian and I'm specializing in diabetes care at the moment. So I'm going to be giving the nutritional perspective regarding diabetes.
Nice. Right, my name is Khalid Keshta. I am a diabetes and obesity control specialist, personal trainer, bodybuilder, and a civil engineer. I always forget that civil engineer in the end. But yeah, I also own and run the Diabetes Academy, the diabetes platform, and the brand K-Shred. And I represent a lot of diabetes organizations such as the JDRF and Insulin. And most importantly, I'm type 1 diabetic for 9 years now.
All right, great. So we're going to be having a multidisciplinary approach. Someone who knows what the physiology is like. So this is me. I'm going to be telling you what diabetes is and how it happens. Rebecca will tell you how to treat it, especially when it comes to type 2 and food-related problems with glycemia. And Khalid will give us his personal experience with diabetes, what it's like living with diabetes, and any extra knowledge he would have about the condition. All right. So it's going to be very conversational. It's not going to be a course. We're not going to be writing on a board or explaining anything. So I'll start just by giving you a small introduction on diabetes. Diabetes is a very old disease. It's not a new one. I mean, the first time diabetes has been described was in 1500 BC, before Christ. And it was found in a papyrus, so the papyri where the pharaohs used to write, and in hieroglyphics. This is where Khalid's from. And there was a physician who was called Hesira, who had described a patient who was losing so much weight inside his urine. And that's all we know about that person. So there was a description of somebody who was losing all his health in his urine and losing weight. So since 1550 before Christ up till now, so many things have changed. If we really want to look for the term diabetes, it comes from the Greek, which means to flow. So diabetes was not a description of sugar. It was a description of a lot of fluid and a lot of urine. In the Middle Ages, so it's about 1200 after Christ, there used to be people called the water tasters. These would realize that there were some people who were urinating down the streets and ants would come and eat their urine. So these people thought there must be something in the urine that is attracting ants. Luckily, medicine has evolved since then because the water tasters used to do exactly that. They would taste people's urine and see that it was sweet. That's why the disease is called diabetes mellitus. So it's a lot of fluid that tastes like honey. Okay, so this is what diabetes is. Diabetes happens when the level of sugar in the blood is very elevated, all right? It's much more elevated than what the body can control. And the body controls increase in sugar by secreting insulin. Insulin is a hormone that is made in the pancreas that is secreted according to the level of sugar in the blood. So according to the presence of insulin or its absence, we have different kinds of diabetes. The most common one in today's world, where everybody is gaining weight, changing their eating habits, practicing sports less and less, this is the type that is due to having a resistance to insulin. So it's as if your body is making some sort of rust over the keyhole, where the insulin, being the key, has to open the keyhole and has to open the lock, and the sugar would go in the cells. So this is type 2 diabetes, where the body still has insulin, but it is having a resistance to its action. Type 1 diabetes is when there is no longer any insulin in the body. Okay, so this kind of diabetes needs to be treated with insulin. And I'm gonna let Khalid give us all the details on that and not bore you with a lot of medical information. So, what are the numbers that we should know and what we should look for? How do we diagnose diabetes? How do we say somebody has diabetes? Well, we have three things to be able to diagnose diabetes. First of all is the sugar while you're fasting. So this is sugar, the sugar level that you would get before having eaten anything during the day. Normally, it should be less than 100 milligrams per deciliter. To get to the millimoles, in some countries where you're using the millimoles, you're going to have to divide that number by 18. If you have no diabetes or no risk of diabetes, your fasting glucose level is less than 100. 2 hours post meal, there are also normal numbers of glucose. So a normal number 2 hours post eating would be less than 140. And then there's something called the glucose level, like the HbA1c, the glycated hemoglobin. This shows us how much sugar there has been in your blood for the last 3 months. So a normal level of this percentage is less than 5.7%. The next step is prediabetes. This is when you have a risk of becoming a person living with diabetes, a higher risk. So while fasting, your sugar level should be between 100 and 125. 2 hours post meals, it would be between 140 and 199. And your HbA1c, your glycated hemoglobin, would be between 5.7 and 6.4%. Now, to diagnose diabetes, to say that the person truly has diabetes, your sugar level should be over 126 and it should be at least twice. I mean, we're not going to diagnose a person based on just one number of a fasting sugar. 2 hours post meal, you should be over 200, and your HbA1c, which is your glucose mean, like the average over the 3 months, would be above 6.5%. Why do we just keep on repeating to everybody, careful with your sugar levels, make sure that you are well controlled, make sure that your sugar is not too elevated? It's because we are worried about organ damage, what happens when there's a lot of sugar in the body. Let's try to get the analogy. Imagine trying to suck out some honey in a straw. The honey would not get into the straw. And the thinner the straw, the more difficult it is for the honey to get into that straw. This is the same thing that happens when there's a lot of sugar inside your blood. When there's a lot of sugar in the blood with everything that is beneficial in it, so oxygen carrying capacity, so defense mechanism for the rest of your body by having your white blood cells, they would not flow correctly into your vessels. The smaller vessels, being like the thin straw, are at a higher risk. Where are the thinnest blood vessels in our body? They're in the retina of our eyes, they are in the kidneys, and in the lower limbs and the limbs that are away from the center. This is why sometimes you would hear of people having blindness due to diabetes, or having kidney disease and having to dialyze due to diabetes, or having bits and pieces of their toes, then their feet, and then so on and so forth, cut off because of diabetes. The other bigger vessels are also affected. The bigger vessels are those that are present in the neck. So you have the carotids that are supplying the blood to the brain, the ones in your heart, the coronaries that are nourishing the heart with blood, and in different organs. So if these get hit, you would have things and diseases like strokes, heart attacks, problems with other vessels in the body, and so on and so forth. So this is why we are always careful and always telling people, first thing you can do in diabetes is to prevent the disease if possible, prevent yourself from getting it. And if you do have the disease, it's important to prevent the complications. So as long as we're talking about prevention, especially when it comes to type 2 diabetes, so the one when there's a resistance of your body towards insulin, it is very important to keep a better lifestyle as a first step to try to diminish the risk of getting diabetes. And nobody is more perfectly placed to discuss lifestyle modification and eating habits than Rebecca. So Rebecca, would you like to give us your opinion on what to do with diabetes and prevention?
So just like you said, there's this period before you get diagnosed with diabetes where your blood sugar levels are higher than normal, but not high enough to be diagnosed as diabetes. And it was previously known as pre-diabetes, which is this part where the fasting regulation of the glucose and everything is just not right. And this is where a nutritionist would come to play a role. not only in terms of prevention, in terms of like preventing diabetes, preventing complications from diabetes, but also helping with the treatment of diabetes. So nutrition plays a big role with that, because diabetes is somewhat silent. So people don't see the seriousness of the disease at the beginning, because they don't sense any symptoms when they're diagnosed until later on. So this is why we take advantage of that time, so that the complications don't come sooner than they should. So complications, as Rawan said, with the blindness, with the neuropathy, with damage to the nerves, and so on. So nutrition plays a role in all of these things. It also plays a role in type 1. So I'm sure Khalid would agree with me that nutrition and exercise play a huge role in type 1 as well, in addition to everything else regarding the insulin. So when I talk about nutrition, I need to emphasize that the pleasure of eating is very important. It shouldn't be removed from a person's life. And how we provide our nutritional treatment is individualizing. So what I say is going to be a general recommendations. However, every person's lifestyle is different. And this is also very important, that it's not just diet, it's not just exercise, it's lifestyle, it's not smoking, it's cutting down on alcohol, and it's choosing the nutrient dense foods and having some behavioral changes. Because we could sit here all day educating you about what is right and what is wrong. But in order to change behavior, it has to come from within, and it has to come from the person. So in terms of nutrition, let's focus on fat, carbs, and protein to start with. The macronutrient distribution, which is the biggest fuss people make about regarding should fat be high, should carb be low, should protein be high, we still don't have conclusive studies that tells you this is the right percentage, this is what we should be consuming. However, I can say that the ketogenic diet, which is super trendy with everybody, is not the right choice to make, especially with diabetes. It is true that there are short-term studies that show insulin resistance is improved with ketogenic diet. However, on the long run, it could do more damage than good. And that key that Rawan was talking about, this insulin that comes and opens the door for glucose to go into the cell and out of the blood, that saturated fat will make it more difficult for that key to work. So this is the way to think about it. Also, carbohydrates shouldn't be cut down because they are the primary source of fiber. We find fiber in legumes, we find fiber in fruits, and in the skin of the fruit. We find fiber in brown bread and brown carbohydrates and brown pasta. So if we are cutting down on that, we are cutting down on fiber. And for those of you who know me, we know how important fiber is. I think Khalid and Rawan can agree with me regarding fiber intake being the biggest deal, because it reduces sugar spikes and it helps with satiety. You feel full for longer. When you choose fiber-rich foods, you will not feel hungry and this constant craving. When it comes to protein, I always suggest that protein is added with carbohydrates in order not only to make you feel full, but as well with the sugar spikes and the sugar rise in our blood. Fat is not our enemy. It's about the quality and not about the quantity. So when I say quality, I mean the MUFAs, the omega-3 good sources of fat found in nuts, found in avocado, found in seeds, and found in fish. So I encourage people to be consuming 2 to 3 portions of fish a week, and not to worry about fruits, because I know that many worry about fruits and tell me, well, I have diabetes, I think I shouldn't be eating fruits. Fruits are bad for you. They help your sugar spike. That's not the case. It's about the number of fruits that we're having and how many exchanges and when we are having the fruits. Regarding exercise, because I want to let the conversation lead to Khalid, exercise does not mean membership in the gym. Exercise means being active, it's moving at least 115 minutes in total per week, and not being lazy or sedentary 2 days consecutively. So we try to avoid people having 2 days of no exercise following each other. And one final comment I want to make about nutrition, and a general thing that everyone should remember: stay away from beige foods. Beige is in the processed, high in salt, high in sugar. Go for the colorful foods, go for the fruits, go for the vegetables, and fill your plate with color more than the bland type of foods, which we call beige foods. So Khalid, can you tell us more about exercise and type 1 and your experience?
Right, guys. So like what Rebecca said, exercising doesn't mean squatting or deadlifting. Exercising in the diabetes world, it means physical activity. So you will be surprised that the best form of physical activity or exercising to drop your blood sugar levels will be walking. It's not running, it's not, doing extreme sprinting or anything like that. So exercising is very important to improve your insulin sensitivity. So you're going to be needing less insulin to inject, or to even get the nutrients in, because you're going to be utilizing the nutrients that you're having more. So I don't think there's an argument about whether exercising is important or not.
Even walking.
I'll talk a bit. All right.
10 minutes, and if they come and tell me that I'm not a walking person, I don't like to walk, they could start at 10 minutes and then they can move forward to 20 and to 30. So baby steps. These sudden changes shouldn't be happening, correct? It's all about gradual.
Always, yeah. I mean, with anything, that is the case. You can't get into fifth gear while driving a car. You have to take it step by step. And this is the case with all types of exercise, not just even walking. But why am I mentioning this? Why I mentioned walking specifically is because people don't get that huge effect, that low intensity exercise, physical activity. I prefer using physical activities that doesn't induce stress hormones in the system, benefits your body. Mm-hmm. A lot of people, for example, they go and exercise and they find that their blood sugar elevated, even though they are exercising, therefore they're burning calories, burning sugar. But they don't know the fact that not all exercises will have the same effect. And some exercises will induce stress hormones in the body, and stress hormones tell the liver to dump glucose in the blood. That's it, high in blood sugar levels. Definitely, it's not wrong to do these sort of exercises, but have to understand how to manage your blood sugar levels around it. Yeah. And I'll get into this, in a bit. Yeah. I want to talk first about type 1 diabetes. Type 1 diabetes could be as simple as a flu, as a very basic flu, or as bad as a stage 4 cancer, put it that way. I'm not scaring you, but whether you choose to, whether you determine it's going to be like the first option or the second option is down to your management of diabetes. So that's why it's our priority all the time as type 1 diabetics is to have blood sugar levels within value, within range. Your priority is to work on your blood sugar levels, not on eating a specific type of protein, not on doing a specific type of exercise. Your priority is this. Once you are able to achieve that, getting your blood sugar levels in the normal range, and no type 1, by the way, can do it all the time. So even normal people, they don't have a straight line. So if a person without diabetes, they check their blood sugar levels before eating and after eating, there will be a spike. But their spike will be within range, within the 4 to 8 millimole per liter, or the 72 to 145 deciliter. Us type 1s, we still, that peak is necessary. No one can get rid of it, and you can't have that. No one can have that. And also, no one is 100% in range. Yeah. So for type 1s that are here on this right here, if you woke up today, for example, and you find yourself hyperglycemic, or you went through a hypo, we all go there. We are all suffering from that specific thing. And it's not gonna, obviously, as I said, it's very important to keep in range, but it's not gonna affect you massively if you go hyper once, and then now you understood the error, you understood why you went hyper, and then you're gonna try to manage it the next time. My slogan all the time with diabetes is prevent, not treat. So very important for us people that we don't wait for our blood sugar levels to go high or low to treat it. You want to prevent it in the first place. People, when they get diagnosed with diabetes, I think I would say even 80% of the people, when they get diagnosed with diabetes, straight away, they imagine what Rawan said. He said about the complications of diabetes. Oh my God, I'm going to lose my eyesight. I'm going to have amputations. I'm going to struggle. I'm not going to get married. I'm not going to get pregnant, stuff like that. That's the problem. This is why it's the lack of understanding of the condition causes that kind of thinking. don't ever draw an image, okay, of type 1 diabetes without understanding what causes the complications. So if you're not managing it, that is going to happen. If you're managing it, nothing is going to happen. That's exactly what it is. There is no in between. So yeah, so I just wanted to get that out. Priority people, control blood sugar levels. Type 1 diabetes isn't a big deal. Of course, it gives us challenges. Me as a bodybuilder, the challenges that I have through competing or even through my normal days, you know, dealing with my blood sugar, it's a 24/7 job. So we have that, but then it's our choice how we want to deal with the challenge, whether we want to, you know, deal with it positively or we want to take it as an excuse and, you know, give up. If we take diabetes as an excuse to reach anywhere, achieve anything we want, that's when you enter that dark circle of, you know, the complications and the depression and the mood swings and all these stuff.
I'm curious if within those 9 years you were ever at a state where not did you feel like you wanted to give up, but you were tired. And I want to know how you got yourself to be the positive thinker and looking at the bright side of things.
I'll be honest with you. When I got diagnosed, I was happy. Wait, I'll tell you how. No one normally is happy to be diagnosed with type 1 diabetes. In the end of the day, it's a chronic condition. I'd rather not have diabetes, full stop. But I was happy because I was in an extreme ketoacidosis pre-diagnosed. My blood sugar levels were 47 millimole per liter, which I think equates to 800 and something.
Pretty high.
Yeah. And I can see it. It's not just, it wasn't only digits. I can actually feel it. I can see. I used to drink a lot of water, you know, very dehydrated, use the toilets a lot, extremely lethargic. I couldn't function. I used to play football back in the day. So I used to play football professionally here. And I swear to God, sometimes I see the football too. That's how bad my eyesight went and my lack of concentration. So I felt miserable. Once I at least knew what was wrong with me, I felt revived. Straight away, took me to the hospital. We did they gave me insulin drips. I got knocked out. I went hypoglycemic when my blood sugar was 15. Can you imagine how high it was? Like 15 millimole per liter, which is hyper. It was hyper for me. And then I woke up. I felt like a new man. Amazing. This was when the diagnosis happened. Do I get tired of diabetes? There is something called diabetes burnout. Any person with type 1 diabetes will suffer from it. That what it means is I had enough. Not I had enough that I'm not going to do anything about it. No. I'm still managing it. I'm still injecting. I'm still doing what is. But I really, man, I don't want to have diabetes. My workout has got ruined. My day, I'm so tired. I went through a severe hypo. I ruined my diet and so on. So definitely I get that. I'm not a Superman, but I would never give up. So that's the answer to the other part of the question. You just can't give up because it's a part of your life. You said it's a lifestyle, and it's exactly that. Yeah. It's not only nutrition. It's not only exercising. It's your life. You're living type 1 diabetes.
You learn to live with. Speaking of hypos, when I saw a story that you put the other day when you were lifting weights and then you had to put gummy bears in order to raise your blood sugars. So is this something that you've also learned to just manage and live with? Because being in a hypo state, I know Rawan told me once that she triggered it and it's not something she would want to feel. So how is that with you?
Yeah, hypoglycemia is terrible. Obviously, it differs in severity depending on how low you go. Sometimes sometimes you're very low that you get knocked out. It never happened to me, thank God. But sometimes I've reached, I think the lowest I've reached was 1.8. 1.8, I should be knocked out. How I deal with it is, again, I try to prevent, not treat. But if it happens, I always must have a sugar supply with me wherever I go. So I must have sugar and I must have insulin and I must have my monitor to check my blood sugar levels, which for me is just the freestyle libre here. Yeah.
What is your treatment, Khalid? Can you tell us what treatments you went through? Were there always just injectables? Have you used something more electronic like the pump? Is there anything that you would tell our viewers, like which one do you prefer? Where do you feel safer? How has it changed your daily life? Which ones are working better for you?
I've been on injectables for years, can't remember exactly how long. And then I jumped into a pump. It was called an AccuCheck Insight, and that pump had a cord. So basically, it was like the infusion set gets stuck on your cord.
Had a catheter with it, yeah.
Yeah, exactly. And then the cord attaches to the pump itself, and it was like this big. I actually have it in the drawer, and you just put it in your pocket or in your belt. Problem I had with this one is when I started exercising with very high intensity, I couldn't have that. I couldn't have that cord. So I used to take it off while exercising. And again, doing some types of exercises, my blood sugar elevates already, having the background insulin. So taking that off, even more hyperglycemic. So I stopped using that pump, back to injectables. I was managing well till I started suffering from something called dawn phenomena. So
that is. Can you explain to everybody?
Yeah. So for people that don't know what dawn phenomena is, it's basically when you wake up hyperglycemic for no reason. There are hormones that got induced in your body, just produced randomly, and this happens to every individual, even people that don't have that type 1 diabetes. Obviously, let me first say what the hormones do. They tell the liver again to dump glucose in your bloodstream, so your blood sugar increases. People without diabetes, there is a balance in their body, so no problem with that. But again, with us, sometimes it's not high enough. Sometimes it's a lot that it elevates your blood sugar very, very high. But the problem wasn't waking up hyperglycemic. Problem is the insulin resistance that happens from it. So
cortisol.
Yeah, exactly.
Cortisol, because people who are sleeping are supposed to have a good amount of sugar into their system while their body prepares to wake up, because we need the sugar to be able to use it in the muscles to get out of bed and start our day. So as you were saying, it's very controlled in people who do not have diabetes. Some people having diabetes may not have that much of an explosive dawn phenomena. And some of those, just like as you're describing with yourself, had a very explosive or a very important dawn phenomenon.
And you can't prevent it. It's hormones in the body. It's just unpreventable. The only way to tackle it, not to prevent it, is either to wake up at the time where it happens and just inject insulin before it, or have a pump. Because what the pump does is that's the joy of the pump. I'll tell you now, I'm on another pump. I'm gonna talk about it now. That is actually the pump, it's wireless. I can control the basal. So as opposed to a pen, if I say, for example, normally with a long-acting insulin, I'm gonna take 20 units once a day. That 20 units is going to be spread over the period of the long acting. Let's assume it's 24 hours. Okay. With the pump, I can tell the pump, okay, I need to take 10 units between 10 p.m. and 2 a.m. And then I want to increase it to 15 between 2 a.m. and 6 a.m. where maybe the dawn phenomena happens and so on. And what happens is the dawn phenomena, so the dumping of glucose still occurs, but my body is absorbing it. So I wake up completely fine. I'm not hyperglycemic. And again, most importantly, I don't have the insulin resistance, because I used to struggle big time with insulin resistance with breakfast. Most of people that have type 1 diabetes, you'll find out that they inject more insulin during breakfast as opposed to any other meal. It is because of that. It's because of the hormones that happens in the morning, that gets produced in the morning. It affects the values that they need to inject.
Very, very well.
Yeah. So right now, okay, so I forgot to mention, right now I am on a pump, right? So it's this one. Can you see it? It's called the Omnipod. It's made by Insulet. And yeah, why am I on it? It's wireless. So
there's no cord. Cordless. Cordless, no catheter.
Cordless. All I do is I inject insulin using this device. That's it.
The PDM.
So I don't mind injections, because I know a lot of people, they go on a pump because they fear injections. But with me, that wasn't the case. It was just that dawn phenomenon. And thankfully, it sorted out.
Did you have any serious complications of your diabetes, such as DKA, which is diabetic ketoacidosis, when your body starts destroying fat to get energy since it cannot access the sugar? So it starts using the fat. once you use the fat, you get fatty acids that have the risk of turning your body acidic, and the ketones, which is one of the things how we know that sugar levels are very high in patients who do not have insulin. So this is for people who do not know what a diabetic ketoacidosis is. It could be a very dangerous situation. So did you ever have that, Khalid?
I never had it since the diagnosis, thank God.
Okay.
Because I never allowed. So I definitely went up to 20s. So 20s translated is going to be
Times 18. So
400, let's say 400, yeah, or so in blood sugar levels. But it was never long enough to get into the ketosis. I'm saying this because, again, a lot of people, especially on social media, they think that my control is on point. I'm 100% all the time, so on. If I show you my freestyle Libre reading, you're going to be shocked. But the difference is, I would never know that I'm hyper and leave myself. Or I would never know that I'm going to go hyper and say, okay, I'm going to treat it. Once I go hypo, I'm going to treat it. And this is how I urge people with type 1 diabetes to manage their diabetes. Because if you look at I think, who said that question? Someone said something about workouts or so, or how do I can't get big or something like that. It is all about this. Once your blood sugar levels are in range, you work out or you get big or you get small like a non-diabetic. That's the difference.
Yeah. There was somebody who asked, what are your suggestions? I mean, I think what they mean is, what is your personal experience in calculating your carbohydrate ratio or your insulin to carbohydrate ratios?
Right. Okay. So there are a lot of equations and numbers and stuff online. Seen people using them and it's not working for them. And this is for the sole reason that diabetes is very, very subjective. So my diabetes is different to yours, Rahul. And my diabetes could be different to mine in a month's time, okay? So I don't agree with someone, deciding the numbers for you or giving you an equation and, just put your weight and, yeah, it's gonna work it out. That's not the case. I used to be, in the same probably few months, I used to be on 14 units of long-acting insulin and 32 units. That's how it differs. My way, so how I help clients to calculate their insulin to carb ratio is to actually physically do it, physically give it a go. You, for example, I'm going to just, anything that I'm going to say is just an example. So it's up to you whether you want to do it or not. I'm not recommending it. But for example, you know that your insulin to carb ratio is 1 to 10. So you're injecting 1 unit to 10 grams of carbs. How do you know that? You've been told by the doctor, or that's what you've been doing, and your blood sugar is not getting managed properly. Let's just put a value to it. You wake up one day, you wait till the morning effect that we mentioned about the hormones disappears. So let's say 1 p.m. or so. Check your blood sugar levels, make sure that it's in range, and then get a can of Pepsi or Coca-Cola. Why am I saying the can? Because you're going to read exactly how much sugar it has, 30 grams or 33 grams of sugar. Drink the can, inject the amount of insulin. So if you're a 1 to 10 and it's got 30 grams, you need 3 units. Inject and then test half an hour afterwards, an hour afterwards, an hour and a half afterwards, 2 hours afterwards, and check the trend. If you went hyper at the end, it means that you're not injecting enough. Your insulin to carb ratio needs to increase. So it's going to be like 1.5, for example, per 10. If you went hypo, it means that you over-injected. That's all. That's the only, in my opinion, that is the way to do it. Otherwise, how else could it be accurate? I mean, you tell me, doctor, if you have any other ways.
This is the best way to do it, tried and true. So this is what we say to people. We give them a set meal. Like we tell them, we're going to give you a meal with 50 grams of carbohydrates. And we are assuming, for example, for every 10 grams, you need 1 unit of insulin. Just give them the meal, making sure if these are fast carbohydrates because we're giving them fast insulin. Make sure of the content of proteins, and fats in it, not to slow down the absorption of these carbs so that the insulin could still be active. So, Rebecca, can you give us examples of what could be counted as 10 grams or 20 or 30 grams of carbs?
With the biggest and the primary one I use is fruits. So every fruit exchange is approximately 15 grams of carbohydrates, and they differ from one to another. Like we have 12 cherries versus half a mango versus an apple versus a banana. So this is what I go for. In terms of slices of bread, also applies to it. One toast I say is 15 grams. And this is how I teach my patients when they come to me regarding carb counting, is that we go through a list and I just guide them and I tell them that look for the grams of carbohydrates that are available in the meals, and then they just get the hang of it, because then this is how they're living in their lifestyle. Unless then they go to buffets and then they have invitations and they have big lunches, and this is where I feel like they tend to mess up a bit and get confused with the carbs. But in general, after giving a guidance of the grams of carbohydrates, they're good to go. And just like Khalid said, it's patient dependent. So it's just depends on how efficient you are and how responsive your insulin is to that.
To that moment.
Mm-hmm.
Khalid, do you have any advice for people? Like, we know, we as doctors, we tell patients or people living with diabetes, when you have a hypoglycemia, there's something called the 15-15 rule. You would take 15 grams of carbohydrate and you would wait 15 minutes to just check your blood sugar and see if there is a response. What we usually tell them, 15 grams of carbohydrates, we prefer it to be fast sugars and not 15 grams of chocolate, not fruits, not something with complex carbohydrates. I'd need rapid carbohydrates. So what we usually say, for example, 3 cubes of sugar, chew the first 2, let the third one just melt in your mouth. Don't panic. A hypoglycemia is not dangerous unless you're crossing the street and you faint, but that's a different story. So generally, it is not a dangerous situation. Just calm down, take your sugars, for example, 3 small cubes of sugar, a small can of Pepsi, you know, the tiny ones, the ones in the airplane, half a glass of juice. And these are usually good ways. However, I've seen a lot of people living with diabetes who have been trying different kinds of candy, because candy is the fastest thing you can put in your purse, in your bag next to you, and a good excuse. Have you tried any? I mean, we've seen your video with the jelly bean. Can you give us like your experience with how many pieces of candy would you take for which would measure for you as a 15 grams, or things that we don't usually talk about because we don't experiment with them?
Yeah.
So as you said with the chocolate, why chocolate is not recommended is because of the fat content of the chocolate as well. It slows down the absorption of carbs. So rule is simple carbs. Get that out of the way.
Yeah.
Simple carbs, it could be candy, it could be juice, it could be fizzy drinks. It's even, I mean, it could be juices like fruit juices. I know people, I don't know how it works, but I know people that treat their hypo with a banana, even though it's a complex fruit. I've seen a lot of people, by the way. It's not one or two.
Banana and honey. They tend to put together when both are not the best, right?
Yeah, I don't know. But yeah, banana was a bit shocking for me because I actually use it before exercising because it's a complex. So, for me, definitely the 15-15 rule doesn't work. 100%. No 15 grams of carbs is sorting my hypo out.
Yep.
It depends on the severity. So if I, for example, go hypo while I'm asleep and I allow it to drop very low, so I'm in the 2.5 range or so, now it means that I'm gonna stuff my face with whatever is in front of me. So for people that didn't experience a hypo, you wouldn't really get what I mean, but if it's bad, it's bad. You won't care. You won't care what you're eating. Of course, I'll always care about that it's a carbohydrate source. I'm not gonna go have some chicken or something. But I won't care about the amount. I will be, stuffing it, because there is a feeling when you're hypoglycemic of hunger, severe hunger, and weakness. Yeah. But if I'm awake, I will definitely sense it straight away. So anything before 4 or 72 or 75, I sense it straight away. So I try to control what I have. I would say probably 30 grams of carbs. Yeah. Just to avoid going hyper, because it happened countless amount of times that I'm hypoglycemic. I eat a lot and then I go hyper. So I inject insulin and then I go hypo. So I eat a lot and you don't want that.
And you're stuck.
And what?
And you would be stuck in a vicious cycle.
It is, and your body gets exhausted. Some hypoglycemia really, really exhausts your body. I think, again, diabetes.
There was something I wanted to point out about the hypo is that once you fix the 15, they usually recommend that within an hour, you have a sandwich, you have a complex carb just to stabilize it, and not to drive within 45 minutes to an hour of having that hypo, because there may be a risk that you get hypo again because your liver is trying to get back its glycogen. So with the hypo, I'm sure once it's done, you're feeling better, but like try to have a sandwich or some complex carbohydrate after it just to stabilize it.
To avoid the drop, because it's different. It depends what caused the hypo, because if it's done post-exercise, means your metabolism is high, and most probably you're going to go hypo again if you don't. Julie asked in the chat, said, I've been getting Dawn phenomena a lot lately and it's horrible. Is the pump the only way around it? I prefer no pump. Julie, I'm very sad to say this. I think so. I don't know if anyone else got any other solutions, but it's
waking up and injecting an extra injection of insulin, but then you're ruining your sleep and you're not getting any recovery of sleep. So,
but also with the injections of the short-acting insulin, how much are you going to take and how long is it going to work for? And it peaks. With the pump, it drops every half an hour or something. It drops like 0.2 units. So I think, a pump is
we can do something. I mean, I'm thinking of what Jolie would like to know. She doesn't want a pump. Sometimes it's not a rapid insulin that we give, but it's an intermediate insulin. But then again, there's also the risk of an intermediate insulin, which would be working. It's not going to peak automatically, but it's going to stay a bit longer. So you have a risk of stacking of insulins, the insulin from the intermediate, and then you put on top of it your rapid insulin, and then the slow-acting insulin. It could be a bit complicated. So this is one of the reasons why the pumps were made. You could try. I mean, it's a trial and error thing, but we're trying to make living with diabetes a bit more manageable. Right. So waking up and putting rapid insulin or intermediate insulin is not truly a long-term solution. So I am with Khalid. I mean, it's a good idea.
Julie said the pump exploded in two friends. What? How?
I've never heard that. I know that they were working in the heat, but I don't know of any pump exploding.
Julie, that would be interesting to tell us the story in the chat, please.
Khalid, you were asking Eric a question about if he's over his honeymoon period or not, and you promised you would explain what the honeymoon period is. So I'll let you say it in your own words.
So Eric, honeymoon period is where the pancreas is still producing minimal amount of insulin after you got diagnosed, which means two things. You eat with some people, the insulin that the pancreas produces is enough for them not to take insulin, or they're going to take lesser amount of insulin, but eventually everyone is going to be dependent on insulin. Why did I ask if you're on a honeymoon period? Is because some people somehow prefer the honeymoon period, but for me, I think it is a it is a confusing stage. Because there is insulin in your body, you're taking insulin, you might go hypo, you might go hyper, you might be in control, not a problem, but then the lesser insulin the pancreas produces, you have to increase the insulin that you're injecting, and it's just like a roller coaster. It works perfect for some people, but again, inevitably, every type 1 is going to be injecting insulin anyway. So for me as a person, when I got diagnosed and when I learned about it, straight away I was like, I want to get out of the honeymoon period if I am on it. That's why I'm asking you. A lot of people, they don't manage their blood sugar properly once they get diagnosed, and they try all sort of things, but in reality, it's the honeymoon period. They're not out of it yet. And the honeymoon period could last for a few days and could last for a couple of years or even more, right?
Yes, I mean, the longest honeymoon period that has been recorded, if I'm not mistaken, was about 18 months. And it's always a question whether or not, what would you do? They always ask us, would you rather treat us now, or once there's no more any insulin in our pancreas, then we start insulin? Personally, I would prefer to at least keep some insulin on board in case the honeymoon period is going to end abruptly, not to end up with diabetic ketoacidosis in the ER. And since this is something that's going to happen inevitably, might as well use that honeymoon period where you don't need so many big doses, just to try to get yourself acquainted with dose calculation and how to get better numbers during that time. So this is something that I find very interesting. There's always a question that we get asked as doctors, and they'll be telling us, when is the cell research going to give us a new like a permanent solution for diabetes? Like, I can tell you from the medical point of view, but Khalid has been saying that he works a lot with associations in the UK and in Europe concerning people with type 1. So do you have any new information that has been trending among associations about a possible cure for this?
Well, JDRF are trying non-stop. Excuse me, they're funding a lot of researchers to find a cure. I've read a title that they are on the verge of, using, what's it called? So stem cells.
Stem cells.
Yeah.
Yeah.
But yeah, I personally, you see, I look at it this way. Maybe if there was a cure for diabetes, or if they were going to come up with a cure, maybe I would have been waiting for a cure as opposed to living and trying to achieve in my life.
Of course.
So I'm not even looking. Of course, it would be nice. Oh, I woke up, I don't have diabetes, but I'm not waiting for a cure. I really don't care if it occurs or not. It's important, if diabetes is a fact. For now, all you need to know is a chronic condition, and you have to live your life to the fullest. I don't know, but I believe definitely 100% one day there will be a cure with all the the speed of
last year
technology.
there was a transplant, a stem cell transplant. In the university in Lille in France, because the team that's working there were connected to them when I was training in France. So far, the results are still stable, but I mean, we cannot say it's secure unless we go through a certain number of years and make sure the side effects are not there. But just as you said, rather than wait for the cure, live your life today, prevent complication, prevent a quality of life lost, and prevent days of your lives lost. Just control your diabetes. How, like, as a person living with type 1 diabetes, has it been difficult for you socially? I mean, do you ever get bothered by people asking you, oh, what is this on your hand? Or, oh, don't you feel like living a robot life? You just have tools attached to you all the time.
Have you seen my pictures?
I have. I'm just saying, for those who have not seen your pictures, could you just tell them what it's like living with diabetes?
I love showing off my diabetes. You don't understand. I love when someone says something that is meant to be offensive to people with diabetes. It's actually funny for me. I laugh at them. Okay. When I go on stage to compete, I make sure that the sensor that I'm wearing on my arm, I wear it on my core to actually show people, hey guys, I'm diabetic. Did you even know what that is? And obviously, it's for two reasons. It's for three reasons. It's to raise awareness for people that don't know what that is. Ask the question, oh, diabetics, they wear a sensor. Oh, well, what is that for? Measuring blood sugar level and so on. And then for people with diabetes to kind of get motivated and encouraged that if I compete in bodybuilding, I'm sure you can do your job or you can do your sport, whatever it is. And then finally, obviously, I worked very, very hard as opposed to a person that doesn't have diabetes to get there. Yeah, so I want to show it. I want to show I have type 1 diabetes. and I reached that. So you can, and in the gym and outdoors and so on. Of course, I get the questions of, oh, what is that? Is that a nicotine patch? What is that? If I press on it, what happens? And so on. And I get called Iron Man a lot in the gym because sometimes I wear like a vest, and when I'm training, you can see like 2 big buttons coming out. People that don't know what it is, they are really eager to ask, and I love it when people ask me. I love it. Before having a pump, I inject in public in front of anyone. I don't care. A lot of people, they thought that the insulin pen that I have is actually growth hormone, because being a bodybuilder, of course, bodybuilders are also associated with steroids and growth hormone and so on. Straight away, I'm like, no, I'm actually diabetic. Nah, come on. Oh, you got diabetes because you take steroids. I'm like, okay, yeah, maybe.
These advancement, the fact that you have these, it helps you versus finger pricking. So you've had that for
100%. It's
10 times a day, if not more.
The most important thing for my diabetes is this. Not the pump. I can live with the DON phenomena. I can live with anything else. The fact that all I need to do is to tap my phone to check my blood sugar levels is amazing. I check my blood sugar around 20 times a day.
Yeah, imagine having to do 20 finger pricks. So
I have 10 fingers. So yeah, and I only used 4 anyway. So it was a nightmare. I had, before having the Libra, I used to have like dotted wounds everywhere. There was no place for me. There was no place in my fingers. And also the inconvenience of carrying the kit. And I'm doing my sports. I have to go wash my hands first, and then sit down, get the test strip, put it in the monitor, and check. Very inconvenient. So whoever invented that monitor is going to heaven, I'm sure.
We have a couple of questions to answer. The first one is, can you tell us how we can avoid the hypos and hypers while fasting in Ramadan?
Well, I mean, I'm going to let Khalid give his opinion, but this is what is very important for people with type 1 or type 2 diabetes, and even with gestational diabetes. Once we get to Ramadan, usually the people who are fasting are requested to check with their physicians 2 months before the holy month of Ramadan. We need to prepare you for this. First of all, we need to give you the green light to fast, because there's a risk. I mean, if your blood sugars are not controlled, you have a higher risk of having complications while fasting due to this absence of control. So please make sure you check with your endocrinologist so they can screen you and they can give you the green light for fasting or not fasting during Ramadan. What I can tell you before I give Khalid the chance to give his personal and his subjective answer to it, during the month of Ramadan, people who are fasting are asked whether they have type 1 or type 2, you have to check your blood sugar levels quite often. It should be in the morning before suhoor and after suhoor, 2 hours after suhoor, then in the morning, then at midday, then in the afternoon, then before iftar, and then 2 hours after iftar. So checking your blood sugar levels is very, very important. Second, it's not because you are fasting that you have to stop exercising. So exercising is also something that you should include while fasting, but make sure it's done after iftar and not before iftar. And we would do the calculations in clinic on how to manage your insulin doses, whether, most importantly, for the basal insulin and for the rapid insulins. So these are the medical things that we do. We are trained by the International Diabetes Federation. There's DAR, like DAR studies, diabetes and Ramadan studies. So a lot of the endocrinologists are certified by IDF DAR to be able to take care of people who want to fast. This is the objective medical advice. But Khalid, have you had any complaints? Have you had any extra things to do? Did you see with your clients or people that you are taking care of or going to the gym with and have type 1 diabetes? Is it different?
Okay, so Asil, I did a video about this in Arabic. I'm gonna send it to you, Asil, because I know her Facebook. I have an opinion, and some people will agree, some people disagree. If your health is in risk, then you shouldn't put your health in risk. Put it that way. I'm not going to get into religion, but even in religion, that is mentioned, okay? I think if you can manage your diabetes throughout the fasting period, if you don't go hypo or hyper, okay, there is no harm. But the problem is, what I said earlier is it's very important to prevent, not treat. So you shouldn't wait for yourself to go hypo, and you shouldn't wait for yourself to go hyper. I know people that they go hypo an hour or two before the adhan, and they carry on fasting. You don't understand the damage that you're doing to your body. Dehydration with diabetes is a big thing. That's another point. With type 1 diabetes, and I believe even type 2, Rebecca, you can confirm this, it's very important to be hydrated all the time. Yes. So opinion-wise, so for example, I don't fast. So since I got diagnosed, I don't fast. I think I tried it once, and no way, that's not going to work for me. And I asked a lot of sheikhs, imams in Egypt and here and everywhere, and they said, you know what, all you need to do is to, I don't know how to say this in English actually. تطعم فقير.
Yeah,
feed like someone in need for the 30 days, and that's it. It counts. But again, this is my opinion. I'm not saying you shouldn't fast. It's everyone on their own, but definitely your health is the most important thing. So don't risk it. That is very important.
Help me answer the question. How can I manage levels during anaerobic workout?
Okay, who said that? Okay, I can't read because there's a lot of questions. So anaerobic workouts, we go back to the same point. Shu is anaerobic workouts.
Anshuman. No, Anshuman asked what to do in anaerobic workout. So
anaerobic workouts, guys, for people that don't know, are high intensity exercises such as sprinting, heavy lifting, you know, not like the walking cardio that I mentioned. So it's the same, although it's the same movement, walking, running, but they have different effects on the body. It's very subjective for you as a person, but scientifically, anaerobic exercises tend to elevate your blood sugar levels. Why? Because it puts your body under stress. And again, what I mentioned, it induced the stress that is induced in the body tells the liver to dump glucose in the bloodstream. So it's elevated. But again, there is another factor. There is the actual metabolism increase and the burning of calories and sugar. So you're going to have like two effects side to side. So what you most cases, what you're going to find is you're going to go hyper, and then after the workout, you're going to start burning the sugar, and then you're going to go, and then you might go hypo if you don't understand the concept of it. So it's very subjective. How to manage it? Test before your workout. Do a full-on anaerobic session. Keep on testing during the session and look at the trend. Look at what's happening. You might not experience that elevation in blood sugar levels. I don't experience it all the time. Sometimes I actually drop straight away. So yeah, very subjective. But this is the scientific way of saying it is anaerobic elevates, aerobic drops.
Mm-hmm. They were asking, there's a question about gestational diabetes. We did not talk about this today.
I will give you just a little bit of information. So diabetes, we've said, is based on whether you have insulin resistance or insulin deficiency. So type 1 is when you do not have any insulin, and type 2 is when you do have insulin. At a certain period of time, when you are pre-diabetic, you have an increase in the quantity of insulin in your body, but then it starts decreasing because of exhaustion, and then you would get to type 2 diabetes. Gestational diabetes is diabetes discovered during pregnancy. So when we discuss pregnancy and diabetes, it is very important to know whether the diagnosis is that of a gestational diabetes and not a type 2 diabetes that had not been diagnosed before pregnancy. okay, because things changed. If we're talking about gestational diabetes, it's usually checked on week 24 or 25 of gestation. This is when there are extra hormones in your body that are producing an insulin resistance. I'm going to try to make it a bit more cartoonish. So once I have a baby growing in the womb, that baby is acting like a parasite on the mother. So that baby is taking all the sugar and all the nutrients from the mother's blood. In this case, there is the placenta, which is the sac around the baby, that will start producing hormones, different kinds of hormones, plasma lactogen, plasminogens, and different other ones that are going to produce an insulin resistance in which the cells of the mother are no longer as sensitive to insulin. So the blood sugar would remain elevated, and this would get to the baby. But when these things are out of control, so much sugar is going to reach the baby while the baby is in the womb, and this is going to predispose the baby and the mother to different kinds of complications. For example, if it's done the gestational diabetes is not discovered or not taken care of, there's way too much sugar in the baby's bloodstream. The lungs are not going, the baby is going to start growing a bit too much. The lungs are restricted, so the lungs are not able to function correctly at birth. A baby that is very big, so we say this is called fetal macrosomia, and we usually use the number 4 kilograms. Imagine trying to give birth via a natural vaginal delivery to a 4 kilogram baby. There's a risk on the baby of being stuck in the vaginal canal. So the problem is on the head, the neck, the baby would not get the oxygen correctly, the shoulders could get stuck in the canal, and the normal delivery could be shifted to C-section. And there's a risk on the mother, of course, to having to deliver a baby that is 4 kilograms. On the long term, babies who are born macrosomial or to mothers having had gestational diabetes have a high risk of being obese themselves, and on the long run they could develop type 2 diabetes. And the mother who had gestational diabetes has a higher risk than others to have type 2 diabetes and develop the type 2 diabetes after gestation. So it's very important not to say, oh, this is diabetes of pregnancy, it's going to go away when the mother delivers and we can forget all about it. No, this is an alarm bell. So that's gestational diabetes. To diagnose it, the numbers are a bit different. So diagnosing gestational diabetes at the 24th week of gestation, you would have to have a fasting blood sugar higher than 92 milligrams per deciliter. 1 hour after the 75 glucose with water, the very sweet and disgusting water that you drink at the lab. So 1 hour later, it should be more than 180 milligrams per deciliter, and 2 hours later is more than 153 milligrams per deciliter. The treatment of gestational diabetes, number one, is through food habits and lifestyle modification. And this is where we count on nutritionists to be able to save the person from gestational diabetes. But in case gestational diabetes is still elevated, we would go for treatment, sometimes even having to use insulin during pregnancy.
Whoever knows somebody who has gestational diabetes, they usually suggest 6 to 12 weeks after delivering to screen for diabetes, and then every 3 years after that, because of that risk of getting type 2 again. It's going to be almost more than an hour. I'm going to answer a last question, which was intermittent fasting is effective in managing diabetes. Yeah, we do see studies that intermittent fasting is improving insulin resistance. So it can help in prevention. In terms of management, it depends on the person as well, very individualistic. And when whoever is practicing intermittent fasting, I always suggest that even if they are eating earlier than they should and they're doing the right thing by not having heavy dinners, just to make sure that the hours that they are eating, the window of eating, they're consuming the right number of calories and their needs are reached then, so that they're not deficient in anything.
So Rebecca, I think the Yasmin asked, she just said, what do you suggest for a type 1 diabetic 24 years old to gain weight?
Mm-hmm.
I'll just answer this quickly in 30 seconds.
Yep.
Avoid going hyperglycemic. That's all.
Yeah.
As long as your blood sugar is in range, which I know that you're probably bored from me saying this, but that is the truth. You prevent your body from going into catabolic state. When you're hyperglycemic, your body breaks itself to provide itself with energy. So you can't gain weight if you're breaking yourself. So once that is done, then you look at the nutrition side.
Yep.
You have nutrition, which Rebecca can talk about, and then you've got the exercising. If you want to gain weight, for example, you're not going to be doing an hour of cardio every day. It doesn't work. You don't want to burn this much calories without benefiting your muscles anaerobically. So in terms of exercising, you're going to be looking and doing complex lift, hypertrophy, strength exercises. In terms of nutrition, again, a nutrient that is very important for growth is protein. Rebecca will probably talk about this for recovery and muscle growth and all that. And Rebecca, you want to continue with the carbs and fats?
Of course, carbohydrates is very important. A lot think that protein is the only nutrient that they should be consuming to gain muscle. It's the both of them together, because we have also glycogen in our muscles. We want to replenish that. Regarding weight gain, the same advice that I give, being mindful of everything that Khalid said regarding blood levels. Just don't drink fluid with your meals. Try to eat 3 to 4, 5 times a day, depending on you and your blood sugar levels. Also, just having the full fat dairy, adding the healthy fats to your meals, having a handful of nuts, adding the nuts and seeds, having an avocado shake, and adding these healthy fat sources for gaining weight, and being mindful of the sources that you are choosing. If there's nothing else, I think we could say that this was a very successful webinar. Thank you so much, Khalid and Dr. Rawan.
Thank you so much, Khalid and Rebecca, and thank you for everybody
Thank you for having me.
Of their lives discussing this with us.
Yeah, I hope everyone benefited. And if anyone wants us to repeat anything in Arabic, I'd be happy to do that even privately. That's not a problem. And thank you, Rebecca and Rawan, for having me.
Thank you very much.
All for coming. And you know that our direct message and our Instagrams, you can ask us your questions. And we're very...
So do you guys want to put your Instagram for people that